Emma for next up.
Thanks, Santosh. So at the Royal Melbourne, we seem to have had a bit of a fire sale recently on polycystic kidneys. We've had quite a lot of patients come through and need native nephrectomies, mainly for creating room to accommodate a transplant kidney in the pelvis as the main indication. And so we thought we'd talk around it and talk around options other than surgery and different surgical practices and the kind of evidence to back it up. And there's some local evidence to go in with it as well. And we'll leave plenty of room for discussion at the end so we can canvass what people around Australia are doing with their polycystic patients. So Ashvini is a second-year fellow. She did her first year at the PA in Brisbane. So she's with us for a second year, and she's sorted out our presentations tonight. Thanks, Ash.
Thanks. Can everyone see my screen?
Yes.
I'll just do that.
Perfect.
So our topic today is native nephrectomy in polycystic kidney disease. Are we creating room or creating problems? We can thank Emma Tully for that presentation, name. That was really good. So generally, we're going to talk about an overview. This is the overview of the entire talk. The first thing would be epidemiology and the natural history. And then we'll go through indications for native nephrectomy. And we'll look at whether or not polycystic kidneys ever regress in size. We'll look at the non-surgical options to see what's available. And then we'll talk a bit about surgical options and timing. And I suspect this will be one of the things that would be a point of a lot of discussion. We'll also look at how much space do we really need and go through our experience at the Royal Melbourne Hospital, and then finish off with 3 interesting cases that we've had to deal with in the last few years, and then further discussion and questions. So autosomal dominant polycystic kidney disease is the most common hereditary kidney disease. It affects 1 in 1,000 Australians and accounts for approximately 10% of patients on the kidney transplant wait list. And 70% by the age of 70 will progress to kidney failure. It's good to remember that it's a multi-systemic disease with cysts in the liver, pancreatic cysts as well, associated with cerebral aneurysms, and also aneurysms in large blood vessels such as the aorta and coronary arteries, hypertension, mitral valve prolapse, abdominal hernia, diverticular disease. And there is no cure for polycystic kidney disease to date. What are the indications for a native nephrectomy? I think one of the absolute indications would be a diagnosis or suspicion of a renal malignancy, recurrent and or severe cyst infections, recurrent or severe bleeding episodes, symptomatic nephrolithiasis that can't be managed with lesser invasive approaches, gastrointestinal or respiratory symptoms due to the mass effect of the kidneys, and anatomical space consideration for future transplant. And it's a rare thing, but some patients do actually have intractable pain, which also necessitates nephrectomies. So do polycystic kidneys regress in size? Just the literature search has actually shown that, yes, it can. A total kidney volume of polycystic kidneys can decrease substantially after a renal transplant. And it's shown that the reduction occurs mainly during the early post-transplantation period and then more slowly thereafter, with the mean degree of reduction varying between 12 to 14% within the first year post-transplantation. And the other question that we had was, does total kidney volume actually decrease once dialysis is initiated? And this study here, where these graphs are actually shown where it's taken from, is interesting because they looked at the total kidney volume, which was measured by either CT or MRI volumetrics, which followed the patient over many years in the time points. And it looked at what the sizes, the total volume of the kidneys were doing until the point that they commenced dialysis. And it's interesting to see that the size of the kidneys did increase until the point of initiation of hemodialysis, where it slowly started going down. And it was statistically significant. And then what happens if the patients actually start on peritoneal dialysis? And when they compared the two between peritoneal dialysis and hemodialysis, the polycystic patients who were on PD showed that they actually continued to increase in size, but the patients that were started on hemodialysis actually regressed. And that was also statistically significant. What are the non-surgical options that are available? Pharmaceutical options include tolvaptan therapy and interventional radiological options as well, such as transarterial embolization and sclerotherapy. Tolvaptan has been approved in Australia. It's available on the PBS. It's been shown that it can help to slow progression of polycystic kidney disease. And clinical trials have shown that tolvaptan can slow the rate of polycystic kidney disease becoming enlarged by cysts and also help slow the rate at which kidney function declines. Its mechanism of action is a selective vasopressin V2 receptor antagonist, and these receptors are present in the walls of the musculature of the vasculature and the membranes of the renal collecting ducts. And by blocking these receptors, the aquaporins don't insert themselves into the wall, thus preventing water absorption within the cyst in itself. And this leads to increased diuresis, a decreased urine osmolality, and increased water clearance. The eligibility in Australia is that patients have to be above 18 years. They're not pregnant or breastfeeding. They have stage 2 to 3 kidney CKD, and they also have to have evidence that their eGFR is declining. And that's defined by either a decline of more than 5 mils per minute in 1 year or more than 2.5 mils per minute per year over 5 years. The side effects is diuresis, where it's up to 5 to 7 liters per day. And you can imagine that can be pretty taxing for patients going to get up and wee, at least 10 to 20 times a day. And 5% of patients also developed deranged LFTs, which was one of the biggest worries in the initial, when the studies came out initially. But the benefits have been shown that it does slow the decline in eGFR on average of 1 mil per minute per year compared to a placebo. And it also shows a slowed growth of cysts, which was characterized by total kidney volume on MRI scans. So who does it benefit? These two are the trials that were the landmark trials that were produced, which brought tolvaptan into use. And the greatest impact was demonstrated in patients with CKD stage 3A, where untreated patients had a rate of decline of 4.4 mils. And in the group taking tolvaptan, it actually slowed down by half. And it also showed a similar impact in patients who have CKD stage 2, but less of a benefit in patients with advanced levels of advanced levels of kidney failure. So it's not recommended, therefore, in stages 4 or 5. The long-term outcomes are still unknown, but there have been multiple follow-up studies that demonstrate safety. And one of the recommendations would be that if you do follow-up serum LFTs, you can timely detect and prevent severe drug-induced liver injury. And to my knowledge, there hasn't really been any reported cases that I've come across in the literature of significant drug-induced liver injury in the tolvaptan patients. Transarterial embolization is where coils are placed by interventional radiologists into the proximal renal arteries, which lead to renal ischemia and subsequent atrophy. The effectiveness varies widely, and the degree of volume reduction varies as well. Some reports suggest a reduction in kidney volume by up to 49% in 6 months. In my experience, it's less used for specifically to reduce the size or making room pre-transplant, but more for acute hemorrhage of the cyst, where the bleeding hemorrhagic cyst is selectively embolized for hemorrhage control. Complications of transarterial embolization include transient post-embolic syndrome, where patients develop sort of like a SIRS response, where there's severe flank pain, fever, and inflammatory markers that are elevated. And these patients are managed usually with corticosteroids, rest, some antibiotics, and most symptoms settle by 7 days, and some persist up to 2 weeks, but most are gone by 4 weeks. Other complications listed could be bleeding, iliac vessel thrombosis, or pseudoaneurysm of the femoral artery. But from this picture that you can see on the right, it looks like, sometimes you can demonstrate a pretty significant atrophy in those kidneys that have been embolized. Sclerotherapy is another option. I don't have any experience with it specifically, but this graphical abstract was produced by the Toronto team. And it was a prospective feasibility cohort study, which looked at 66 patients with polycystic kidney disease that had formed sclerotherapy, which is sodium tetradecyl sulfate selectively instilled into the target cysts. And how they do that is under ultrasound guidance, under a bit of sedation, these cysts are aspirated till they're dry, and then they're instilled with this STS sclerosants. And they've reported that there's an associated 21.8% volume reduction in these cysts. And these patients also had a higher measured creatinine clearance by at least 10 mils per minute up to 12 months. And I think this is attributed to the fact that you're not destroying normal renal parenchyma or whatever that's left. You're only specifically targeting the cysts. It's also reported that it's safe, it has minimal side effects, and they've demonstrated that in follow-up imaging studies at 12 months, that the size of the cysts were maintained, reduced in its size. And so they say that it's also pretty durable. When it comes to surgical options, we have to look at it in a few different ways. One would be the staged pre-transplant nephrectomy followed by a kidney transplant. Simultaneous nephrectomy, and that can be either unilateral or bilateral and a kidney transplant, or a post-transplant nephrectomy. Other things with the approach would be, is this something that can be done minimally invasively versus open, whether it's transperitoneal versus a retroperitoneal approach? And there's currently no consensus or guidelines. And therefore, it's an area of ongoing debate and research. I think what needs to be done is, you've got to balance everything, because a bilateral or a unilateral nephrectomy also can have deleterious effects. Like you do lose the endogenous EPO, erythropoietin production. There's a decline in quality of life because reported, because these patients can also have a loss of diuresis and may be required to commence themselves on dialysis. And there's also major operative risks, which is bleeding and the potential sensitization from blood transfusions, major venous thromboembolisms, pulmonary complications, ileus, post-op hypertension requiring ICU admission. This review article was published this year in the Journal of Nephrology in January. And it was one of the articles that basically kind of looked at what we were talking about today, what could be the potential benefits and the potential drawbacks of the timing of native nephrectomy in polycystic patients. The thing that's important to see is that the outcomes here, where the majority of the studies in the literature suggest that there's no significant difference in graft survival, graft function, and patient mortality. And that they looked at a lot of the studies that is available out there from very big units internationally, including the Mayo unit, the Germans, the Spanish. I think it's a good summary, this table, which basically just takes us to the potential benefits and the potential drawbacks of each timing of the surgery, be it pre-transplant or simultaneous. And the recommendations from that was that if you are to do a nephrectomy, a native nephrectomy, they think that a unilateral nephrectomy would be suggested over bilateral, because it has been shown that there's reduced operative time and blood loss. There's a lower risk of complications. There's a faster recovery time. There's more likely a preservation of renal function. There's decreased risk of erythropoietin deficiency. There's a lower probability of hormonal and metabolic disruptions. And there's a potential for a simultaneous kidney transplant as well, or feasibility for living donor transplantation. The post-transplant option here, they mentioned specifically because it preserves the native kidney function and it avoids a period of prolonged dialysis prior to transplant. And it reduces the pre-transplant morbidity and access to being on and avoids the delay in transplantation or being placed on a wait list. What's our local evidence? There is a systematic review and meta-analysis that was published in 2022 that was produced by the Westmead team. And the objective of this was to look to see whether staged or simultaneous approach to native nephrectomy in polycystic patients had any caused any issue in terms of morbidity and graft outcomes. And the primary outcome here was the rate of graft thrombosis. And the reason they chose this to be the primary outcome because it was the universal thing that was reported in all the 7 randomized control trials that was looked at specifically in this systematic review. The secondary outcomes here were the cumulative morbidity of both procedures in the staged approach compared to the morbidity of a single procedure in the simultaneous approach. And, and the results showed that there was no difference in major postoperative complications. There wasn't a significant difference in the risk of graft thrombosis. There was no difference in the cumulative hospital length of stay, and that stage procedures actually had a longer cumulative operative time and a higher cumulative packed red cell transfusion rate. So what approach is the best? And kind of just like this picture, it looks like there's many different ways to get to the endpoint, which is what's best for our patients. If you look through the literature, there's lots of publications about bilateral laparoscopic nephrectomies at the time of kidney transplantation in patients with polycystic kidney disease. And this is the Mayo paper where they've published multiple of their findings, but this is their clinical experience where they do simultaneous with living donors, and it's a hand-assisted bilateral laparoscopic nephrectomy, where the patients are placed in a lateral decubitus position, changed from one side to the other, and then finally placed supine, and a retroperitoneal approach is used to perform the kidney transplant. Their results show that there is a longer cold ischemic time, up to 2 times longer. Their patients required more transfer to ICU. However, their median stay was only 1 day. Their median theater time was 310 minutes versus 174 minutes for a kidney transplant alone. More patients required a blood transfusion as an inpatient in their cohort. The median time to discharge was 4 days compared to 3 days in the kidney transplant only group. All of their patients were living donors, so none of them required post-op dialysis and no one had delayed graft function. But they showed that there was a slower decline in the post-op day 1 creatinine, but they were all similar by day 7. And the complication rates were reportedly similar in both groups when it came to Clavien-Dindo 3 and above. And their conclusion was that there was no short-term or long-term complications on the patient or the allograft. Similar publications with open retroperitoneal approach, such as this one, which is by the Turkish group, suggest that there's also when simultaneous ipsilateral nephrectomies are performed, that it is, their conclusion here was that it's safe. There's a slight increase in packed red cell transfusion, but there's comparable complications in a return to theater rate and comparable renal allograft outcomes. The literature goes on in many European countries, and it's pretty similar as well. So the bottom line and my take home was that most of the literature suggests that it's safe to proceed with simultaneous native nephrectomy at the time of kidney transplantation without significant increase in morbidity in both short and long-term allograft complications. But if you look at the grid of all the publications, the indications differ quite widely. Some perform unilateral, some perform bilateral. Some studies suggested that they only did right-sided nephrectomies despite the size or symptoms. And I think that's more to prove feasibility that it is possible rather than true indication. Some of them only did symptomatic sides as well. So I think the approaches vary, and there's, again, no consensus on what's best. So a tailored, individualized approach is what's required. With the question of how much space do we need, I think it's pretty subjective. It's surgeon dependent. Generally, my understanding is that if the kidneys are not passing below the iliac crest, then there's pretty much space to transplant. And if you examine the patient and you can get a fist below the inferior edge, you pretty much have space for a kidney transplant. But you got to keep in mind that everyone's different and everyone's body habitus is different. You know, a male narrow pelvis will be much different from a female with a wide pelvis. Obesity, the anterior posterior projection of the patient and their abdomen as well should be taken into consideration. So the next bit would be our RMH experience and a review of the cases that we've performed in our hospital from 2011 to 2024. We have 44 patients in that cohort. And I must just mention that the reason why we have only 44 patients is because a lot of the work is actually also done privately, which doesn't fall into our, we can't capture that basically on our computer systems. And part of the reason for that is also theatre access. We performed native nephrectomies on 34 males and 10 females, pre-transplant 30, post-transplant 2, patients who were not transplanted 7, and patients who are still on the wait list are 5. The nephrectomy side was individualized, 26 was the right side, 17 left, and 1 was bilateral. We preferentially performed these as open procedures, so 43 were open and 1 was laparoscopic. And the indications were mainly creating space for transplantation. We had 5 patients who had recurrent cyst infections, 4 for either malignancy that was diagnosed or suspicious, 4 for hemorrhage, 1 for pain, and 1 with mass effect and compression on the inferior vena cava. Out of these, the results, 59% of the patients had no complications. We had 2 ileuses, 2 BP ICU admissions for blood pressure support, 3 lower respiratory tract infections. 1 patient required a blood transfusion, the other was just observed. 1 patient had a rectus sheath hematoma that did not require intervention. 1 had an infected retroperitoneal collection. 1 patient had a return to theatre where at the index operation, there was noted to be a cecal serosal tear, but the patient presented with ongoing bowel obstruction and was taken back to theatre, but there was no obstruction and the cecal perforation was intact. 3 had delayed incisional hernia that had to be managed at a subsequent time. The average length of stay was 4 days and 7 hours. The average waiting time in the staged approach was 384 days till they got a kidney transplant. The average waiting time till we got a live donor transplant was 171 days. And the average waiting time to having a deceased donor kidney transplant was 386 days. Of our cohort, 4 patients died while they were on the wait list. 2 had metastatic renal cell carcinoma. 1 had a complication post an incisional hernia repair, and 1 we haven't been able to determine the cause of death. Before we move on to the interesting clinical cases, I think we can open up the floor to any questions, especially if it was pertaining to our RMH experience.
Who wants to go first? Santosh, you go first.
Okay. Thank you, Ashwini. So far, great. A good presentation. Now, just curious, with that RCCs, yes, I did notice, though before we started the meeting today, I was alluding to the higher number of malignancies that you guys saw in your native kidneys. Now, those metastatic RCC also were those patients who had those primary malignancy in there?
Yeah, I'll speak to this one, Santosh. Yeah, we've had patients who have had incidental findings of high-grade tumours that were not picked up on imaging pre-op for the native nephrectomies, and I think Ash will talk about one of those cases shortly, that have then subsequently gone on to become metastatic and very quickly actually become evident in, malignant pleural effusions and then widespread metastases through the abdomen, despite having clear margins with their nephrectomies. So I think there had been a talk earlier in the series in regards to imaging patients with polycystic kidneys and looking for malignancies and surveilling these patients as well. And so that particular case, as I said, the most recent case that we've had really did prompt a good look at our wait list for patients with polycystic kidneys and making sure that they had had adequate imaging, so contrast imaging of their kidneys to ensure they don't have a worrisome lesion. And beyond that, in patients who we do look at for native nephrectomies, contrast imaging is part of their workup to make sure if we are going to be taking a kidney out, that we're going to be, we're not missing a malignancy and an opportunity to take that kidney out at the time.
Thank you.
Just a comment. I mean, beautiful talk, but fantastic presentation, by the way. Why were they all done open? I mean, I'm amazed. Why aren't you being, little gun? Why doesn't Emma do a little gun laparoscopic or hand-assisted laparoscopic case? I have to say it's no harder. I'm just very surprised they're all done open.
It's such a good operation, Henry. That's why.
I don't know. Oh, I mean, no, I mean it was great presentation. I could ask one thing. What do you use for screening? I looked this up on the internet and I couldn't really find an answer. And there seems to be general disagreement as to whether these patients should be regularly screened for a cerebral aneurysm. I have to say, I've only just, from my perspective, I just thought they needed at least a screening investigation, but not regular screening for a cerebral aneurysm. Do we know the answer? Ashvini, should we be screening these patients every 5 years for the development of a cerebral aneurysm, or?
Well, I think in our institution, we just do a single, regardless of family history, they get, one, and then, unless you see something and you think that, you want to monitor to see if that's growing for intervention, I don't believe they get screened regularly.
No, that's definitely our institution's experience, but the internet would appear to disagree. So I don't know what the answer is. It's another annoying thing about looking things up, isn't it?
I think the other comment to that point is it's not just cerebral aneurysms. We've had a number of patients that have come through who've either had aneurysms, particularly at the bifurcation of the aorta and common iliac, and finding those, monitoring those is an issue, but also that influencing the site of nephrectomy when you're doing nephrectomies to make space has also been a consideration, not to miss those.
I could just add to your complication list, Ashvini, because I had a pancreatic leak, which I've never had before. I've read about it, but I basically had a patient with a massive lake of fluid, which was pancreatic, amylase rich, which required a percutaneous drain. So, yeah.
I can see how that, could potentially happen. Everything's so close to each other. It's just, sometimes it's super tricky, isn't it? Even, do you do it hand-assisted?
Only if they're enormous, but otherwise, if it's small, you can just do it laparoscopically. But they're usually enormous for space. And I suppose my only other comment is that I've only done 2 where we've had a live donor, so we've done the lap nephrectomy on the same day. Try and start early, and then we haven't added huge cold time to the live donor kidney. But most of these people don't, by definition of their family history, don't have a live donor. So
yeah.
Santosh, you've got your hand up.
Yeah, just to add on with that discussion on intracranial aneurysms. I mean, we struggle to convince our physicians to start screening these patients, irrespective of family history and the so-called KDIGO guidelines. But in the last 2 years, we have also successfully screened all patients. And as you said, Emma, we also had a huge number of index patients, which was in one of our earlier webinars we had presented. But more importantly, now what I'm seeing is post-transplant, the screening is even more important than pre-transplant screening, because we actually had a death in one of our patients, a youngster who developed an aneurysm about 3 months after the transplant, after having the aneurysm coil and things like that. So new aneurysms development post-transplant with, once the patient is on immunosuppression, that is some area which we require to look at. And we know that it is the smaller size aneurysms that's rupturing more than the larger size aneurysms. So that is one concern. The question I had for Ashwini was, between the kidneys, do you do some sort of a split function to decide which kidney makes more urine before deciding right or left, or just sheerly by the size do you proceed?
Surely by the size. And whether or not, like, and also, so if we'll go through one of the cases after this, but the other thing was size, and the second thing was whether or not there was presence of any like common iliac aneurysms. And that also has been in the past something that guided us as to which side we take out, and symptoms.
Thank you.
Jerome?
Right, thank you. I guess I just wanted to justify myself, because part of the reason why we did that systematic review about simultaneous transplants and nephrectomies was I've done quite a reasonable number, but the most of them are actually patients with polycystic liver and kidney disease. Often, you know, there's a sort of extreme of the spectrum where the patient's got no intra-abdominal domain at all, and often being considered for simultaneous liver kidney transplant. And so I think that's why I see more of them, and often preemptive. So their major problem is a very large liver, very large kidneys, and preemptive transplants with GFRs, you know, often in the 15 range. And for those patients, you know, I think that's the sort of cohort in which I've been willing to offer them bilateral simultaneous nephrectomy combined with simultaneous living donor liver transplant, kidney transplant, which has been okay actually. You know, you just make a huge laparotomy and then take the kidneys out, and they tend to leave the same time as our normal patients, which is about a week. And I think that's because, you know, you relieve them of such a burden of intra-abdominal mass that it's actually not that bad.
Interesting. Just as a quick question, when you're doing bilateral native nephrectomies, do you have any, or have you noted any issues with adrenal insufficiency in those patients? Or
so I preserve both their adrenals, yeah, which is actually not very difficult. You just yeah, I mean, I guess that, you know, there's always the concern that, you know, the blood supply to the adrenal gland might come off the kidney artery, but so you can definitely preserve both the adrenal veins pretty easily. And they're often a bit hypotensive after that, and you never know why that is. And so some of them, I guess, go to ICU and get some noradrenaline. So I don't know whether there's transient adrenomedullary insufficiency as a result of deprivation of arterial inflow, but I've always preserved both of the adrenal glands physically. But I think it's a transitory concern because, you know, obviously they get steroids afterwards, so that the adrenocortical function is kind of subsumed by that, and then presumably the other parts of their sympathetic nervous system take over the adrenomedullary functions.
Yeah, I suppose the question was in relation to the transient effect of you having been around the adrenal gland and I suppose knocked it around a bit, knocked its blood supply around a bit. But always an interesting consideration. Amanda, you've got your hand up.
I'm just going to say, I don't reckon it's that easy to see the adrenals and make sure that they're fine. It's not that simple. So I think the message is that you do need to be pretty careful. You want to obviously preserve them, particularly if you're doing bilateral, but it's not that easy.
I would agree with you.
I mean, I think, Amanda, we use a Thompson retractor, so basically the exposure is, so it's pubis, so xiphoid laparotomy, and then a Thompson retractor. So you get a very good view of everything. And it's pretty easy.
Which I'd also say is fairly big incision. I do a transverse, fairly small, and I think mostly preserve the adrenal, but I think it also heals really well because you've got 3 layers of muscle. to suture up, and obviously these people are prone to incisional hernias. I think a midline is a big problem.
I mean, we certainly have seen a few hernias with our midline laparotomies, and in fact, one of the patients on our list on our review had passed away during an incisional hernia repair many years after their native nephrectomy. But I think they're all very interesting considerations: adrenals, people's approach, and I suppose people have developed and evolved their own approaches over time, and are comfortable with their approaches, but there are merits amongst them all. Santosh?
Yeah. So here in Adelaide, by and large, our policy is bilateral nephrectomy and transplant in the same sitting. However, I do agree with Amanda that it's not always easy to see the adrenal glands that easily. And I also agree with Jerome that often these patients ends up in the ICU for a bit of supportive to support the blood pressure, because on one side you have a transplant and we require some sort of adequate pressure to drive that transplant kidney as well. Now, with respect to the transverse incision versus the midline incision, the problem, I mean, it's a nice incision, the transverse incision, but at times we have got caught with the typical male pelvis, which is short, and when we put trying to implant or make the kidney sit ideally sort of above the pelvic brim is not entirely easy. That approach there. Because we are trying to do the transplant with the same incision, it can be a bit of a struggle. Whereas a midline laparotomy, I find it much easier to take care of any injuries as well that can come about with this right and left nephrectomy along with the transplant.
Are those specifically for deceased donors or planned living recipients?
No, we've done most of them in deceased donors. We have done, I think, in one patient we've done in a living donor, but by and large, it's been in deceased donor kidneys.
Henry?
Yeah, it was really just to say that there isn't a right or wrong, and it's interesting how you evolve the techniques. But I've probably the last, I don't know, 20 years tried to use a Rutherford Morrison, but not a full Rutherford Morrison incision, just like a hand port. And we've often had to extend the hand port slightly to extract the polycystic kidney because it's usually huge, but it's still tiny compared with an open incision. And it's proved difficult because I'm trying to do it for cosmesis, because we're trying to use the same incision that you'll then extend to do a kidney transplant through. But I'm not sure that's the right way, and it's maybe better to use a totally separate incision. But anyway, we've done that, and we have published a rather dodgy series that Ashwini didn't mention. So that's
I did see.
But basically, in our experience, we did have one wound complication with an incisional hernia post-renal transplantation, but it interestingly hasn't proved a problem doing the transplants through, with a prior surgery there. So I kind of, that's my approach, but it could be completely wrong. It'd be hard to prove, because you could use a lower midline incision. That might be way easier and convenient, doesn't get in the way of a subsequent kidney transplant incision. Usually, but yeah, there isn't a right or wrong, but I think interestingly we had a similar length of stay to your open series. But what I really hate doing is being forced into doing a polycystic nephrectomy when they're not on dialysis, because then they crash onto dialysis and then they stay in hospital a heck of a lot longer. That's my own experience. Absolutely, they stay in because they're getting, they've never had dialysis before, and then they're under your care as the surgeon, and I've found that kind of hard. And they've stayed a long time when that's happened. So I really try and encourage them to commence dialysis before you intervene. But certainly, I think one of my urology colleagues was doing a case for possible cancer. Do you know what I mean? So it's, they're not going to wait. So they're going to crash onto dialysis. So I don't know what your experience is in that setting, but I have found that they've stayed a long time.
To that end, I think in terms of what we do, our approaches are a little bit different amongst the surgeons at Royal Melbourne, but we generally do wait until people are ready to start dialysis before they have their native nephrectomies, and we're not doing simultaneous native nephrectomies and transplants. This has given me a little bit of food for thought, but it probably won't change my practice just yet. But for patients who are ready to start dialysis and need the native nephrectomy, I've been getting them down and putting permacaths in and allowing them to have 2 or 3 weeks of dialysis before they, just to optimise them before they have what is, you know, quite a reasonably large surgery. A lot of those patients are anemic to start off with, so to give them some Aranesp and get their hemoglobin up before they have the surgery to try and avoid red cell transfusion is also, you know, one of the logic behind, part of the logic behind that. And then getting them down, and we would usually then be able to wait this for transplant or proceed with their live donor transplant 6 weeks down the track. That kind of staged approach is kind of, I've found, resulted in a bit of a smoother transition for them. But I appreciate the people's experience with, you know, simultaneous nephrectomies and live donor transplants and having them captured all in one admission. It's interesting to hear what people are doing. Andrew, you're online. I think I saw your name online. What are you doing in Brisbane? Are you there?
Hello.
There you are.
Just quietly listening because just really interested to hear how everyone has a different approach and all the things that we think about people have tried and learned to, you know, good to learn from others' experience. I have to say I've spent my last, you know, 10 years of urology career and transplant talking people out of nephrectomies. So our numbers are certainly very unimpressive. I think I must do about 3 of these a year open. We use transverse abdominal incision. As Amanda, you know, mentioned, what we find at the transverse abdominal incision smaller and they heal better. But that's just our experience. So always unilateral because we ration that bilateral nephrectomy would render these patients anephric, minimal renin, difficult to control blood pressure. And I mean, I think we showed previously that systolic blood pressure less than 100, the outcome is really poor. So we try to just do a nephrectomy on one side. But yeah, I mean, that's what we do. But very interesting talk so far. And thank you, Ash, for excellent talk.
We still have more.
Okay, perfect.
We'll let Santosh have a last say, and then we'll just go on to our interesting cases.
Ashwini, in that paper you mentioned about the transarterial embolization in keeping with the conservative line of management, because these polycystic kidneys are known to have a lot of infection and cysts with infection and stuff like that. So any of those patients actually, did they have a higher incidence of septic necrosis rather than an aseptic necrosis and infarct of those kidneys?
They didn't report on that. So nothing mentioned in the paper in that particular one.
All right, thank
It's
you.
interesting to see actually, because yeah, it'd be interesting to see. And I don't believe they did theirs in any patients who had infective complications to begin with. So they selected their patients purely for size.
Thank you.
Yeah.
Okay,
so
Ash.
I'm happy we can go on to the next bit. We've got 3 clinical cases, which, you know, will just be interesting to see what everyone's thoughts are about. So the first one is a 63-year-old gentleman who's got a blood group of AB. He's not sensitized. He was a marginal candidate because he had extensive cardiac issues. He started hemodialysis since September 2022 via an arteriovenous fistula. His other medical issues was his cardiac disease, where he had an acute myocardial infarction in 2008 and multiple PCIs to different vessels. Up till 2024, where his LAD was stented. He has a permanent pacemaker. He's got a defibrillator. His ejection fraction was 31%. He was on warfarin because he had an unprovoked DVT and AF. He had a previous perianeurysm that was clipped in 2009, and he also had a AAA that was 3.9 centimeters on the right common iliac artery, and it was stable. He was seen by the vascular team and they chose not to intervene and only monitor that clinically. His plan was initially to proceed with a native left nephrectomy prior to activation on the deceased transplant wait list. But after that LAD was stented, he actually had a significant improvement in his cardiac status and his exercise tolerance. He started walking much more with his wife. He sustained significant weight loss through that. And when he commenced on dialysis as well, when he was re-examined during one of his follow-up visits, the same surgeon had assessed him and thought that actually he had a little bit more space on the left side and it was way more favorable. And we brought him back to clinic for a sort of group consensus between the other surgeons. And the decision then was to activate him without the need for a native nephrectomy. I guess I'm curious to see what the other surgeons think about this and whether they've had similar experiences.
Just to add a little bit more to Ash's summation, this was a patient who presented pre-dialysis and who ended up on dialysis as a plan to do that before he had a native nephrectomy. He had extensive vascular consultation with a few different teams who all agreed that wouldn't intervene on that iliac aneurysm. It had been stable over a number of years. And so the decision was to do the left native nephrectomy. So knowing that we wouldn't be transplanting on that right with the aneurysm. But in the meantime, he had another cardiac event and had a stent and was on Plavix. So had a prolonged duration of hemodialysis. And after about 16 months of hemodialysis, we reassessed him and then thought clinically the space had much improved. But this is his current CT, I believe, Ash, is that right?
This is the current one.
Yeah. So open it up to comments to for anybody, but just one of our main considerations was it's a big operation, native nephrectomy, and certainly he is, in our experience, I suppose, a bigger operation than a transplant, and he would be a marginal candidate to get through that. Santosh.
Yeah, so as you said, a 63-year-old gentleman, quite marginal, with clearly a vascular path in terms of poor, he's had coronary issues. He's got an aneurysm, which is probably stable with a stable dissection, and at least from the CT scan, doesn't look like any space. So if you put it into the SOT or one of those calculated 30-day mortality risk, you are looking at 5 to 6%. So the way I would look at it is, one, a transplant is not for everyone, and two, if they're still wanting to push it, then we are looking at a native nephrectomy. That it'll answer two questions. One, it'll tell us whether the patient can withstand a major procedure, so therefore test the heart. And two, yes, you would have cleared the space and then a possible transplant in the future. And of course, you should know that or any surgery in a patient with an aneurysm means patient can have further dissection in the longer term.
Sorry, all true points. Sorry, I muted myself there for a second. Henry?
I don't think he'd get a Guernsey probably from our physicians. I mean, unless I'm misreading the slide, but he's had 4 separate coronary stents, an ejection fraction of 31%, a pacemaker. He's got too many things wrong with him. But I agree, Santosh is right. If you seriously thought he was a transplant candidate, then a test of anesthesia is quite a good test. But I mean, I don't think anyone would be that enthusiastic about transplanting him. So what's the point? Probably. What's the management for his common iliac aneurysm? No management. We're just hoping. We're just going to hope, are we?
Yeah.
Hope it's okay. Yeah, I'm not enthusiastic on from what you've written down. It looks like he's about to have a further heart attack reading the newspaper. So, yeah.
Yeah, interestingly, I mean, the paper presentation does very much undersell him. He's not as justification, but he is somebody who's actually done very well on dialysis, and his ejection fraction has improved from that. That's an old echo. but not by way of justification. We had put him through an anaesthetic review and a cardiopulmonary exercise test, and his parameters have improved on that. Basically, one of the reasons for presenting this was from a clinical point of view. All the markers looking at the size of his kidney and space for transplant have improved since when he was first examined about 2 years ago pre-dialysis, and that was one of our questions when we looked at this presentation, is what might you expect when somebody does go on hemodialysis, or what are other modalities that might help reduce the size of a kidney to prevent somebody from having a larger procedure or a large major procedure before a transplant, you know, to get them out of that, as opposed to it being a test for a transplant. You know, having a procedure he wouldn't necessarily need if he wasn't going to have a transplant. Jerome?
Oh, yeah, thank you. I guess I've just started thinking more and more about, you know, the physicians have got this really strong belief that patients are better off being transplanted based on observational data, largely from the 90s. But, you know, the patients who got transplanted in the 90s and appeared in that, you know, Wolf study in the New England Journal are not this guy. So I strongly suspect that many of these patients who we transplant probably shorten their life. And I mean, this guy's not the worst, obviously, but I'll be with Henry. I think we're more likely to shorten his life than lengthen it with the various procedures that he's going to need to undergo transplantation.
Interesting. He certainly is a very interesting guy. Ash, next one.
Next one is a 68-year-old gentleman, blood group O, not sensitized. He had symptoms of early satiety, reflux, and back pain, but he's never had any cyst ruptures or infections. On his review, we managed to elicit that he had some claudication symptoms on his history, and the clinical examination showed that he was quite difficult to palpate his femoral pulses. So based on that, we prompted an ultrasound of his iliac vessels and his lower limb, even though the CT scan had showed that there was preserved flow through the common iliacs and the femoral arteries, and he had some mild to moderate calcifications of his distal aorta and his common and his right external iliac artery and his left external iliacs. His ultrasound showed that he had a complete occlusion of the external iliac arteries bilaterally. And he also had grossly enlarged polycystic kidneys extending into the pelvis. I guess the question here that Emma might have wanted to bring up was, what would you do in a case like this?
I wouldn't transplant him. But you haven't told us whether he's on dialysis yet. Is he on dialysis already?
He has just started dialysis. And
yeah,
this
so
was
he's gonna wait 5 years for a deceased donor transplant. He'll be very dead. He'll be cremated by then. I would have thought.
I go back to my previous comment. I think we're likely to shorten his life with transplantation, particularly polycystic nephrectomy and transplantation.
Wasn't it interesting, Emma? This guy, there was some question about vascular involvement and transplanting onto like an aortofemoral graft. Has anyone had any, because that was part of the discussion that was documented, but I don't know whether anyone actually has much experience.
I've done it. They died of a heart attack.
What was that? Sorry, Joe?
I did it about a year ago, and they died of a heart attack in the post-operative period. It's pretty pointless.
Yeah. Was that in a graft at the time of transplant?
No, it was they'd had it done before to prepare them for transplantation. I think if you're having major vascular surgery to prepare you for transplantation, you shouldn't have transplantation.
Yeah, we certainly have had a few patients that have come through, not polycystic patients, but that has been part of the discussion, and ultimately, you know, we have come to the same conclusion for all of them at this stage. I suppose this was a case to bring up largely because it was quite unusual to have bilateral external iliac artery occlusion, and these cysts actually on different slides we were able to see that there was some compression. We've certainly had patients have compression of IVC from a very dominant cyst on the right side, but we haven't seen that before. And, you know, there may be other pathology going on there, but it was something for us to keep in mind. It was certainly something that was brought up with clinical examination for him too, and that was why we pursued it. But we'd otherwise, at this early stage, just be having non-contrast CT with this patient. Santosh?
Yeah, thank you. So Ashwini, I sort of differ from the other two responses. Now, the problem is when this patient would come and say, hey, I have a living donor, would you accept? And if otherwise, I mean, you're not mentioning any cardiac issues here. So if it's purely some sort of a large vessel disease, I would first give it to the vascular guys to fix that vascular bed. I mean, it is not always that, I mean, we may be comfortable in transplanting by tapping into the iliac vessels, but the body is not only iliac vessels. There's a whole bunch of vessels into which you can tap the kidneys into. So I would look at it like that. So it depends upon what sort of a donor this gentleman is, this patient is bringing through. And we can always find a way to create space and implant. Yes, we have used grafts in the past. It works well. We use the splenic vessels. We use the native renal arteries. So there's a whole bunch of vessels you can go to. So that shouldn't be a problem.
That was certainly something that came up in the discussion. We did look through his imaging and think about where else we could potentially put the kidney. But yeah, I think the resolution at the end of the day was maybe not to proceed.
He's actually still waiting some contrast imaging to come through. It's only a fairly recent case, but he does have a live donor. And so there's still a little bit to work through, but mainly around the occlusion of his vessels and on contrast imaging what is actually going on there. How about the next one, Ash?
Yeah, so the very last one is this gentleman. So he's a 55-year-old, blood group O unsensitized. He's commenced dialysis in 2020 via peritoneal dialysis. He was active on the transplant wait list until he had a clinical review. So he came in, he got an offer in January 23. And when we clinically reviewed him, we were like, oh, his kidney is actually much larger than expected and much larger compared to his previous clinical reviews with the surgeon. He had 2 scans in the past, 2019 and 2021, and bilateral kidneys did not extend into the pelvis. Based on that, we deferred him from having his deceased donor at that point and proceeded with a right nephrectomy in May 2023. And the histology of this actually revealed an incidental T3A renal cell carcinoma that was completely excised. His initial staging scans had an indeterminate pulmonary nodule, but it wasn't PET-avid. And so he had surveillance imaging, and that was 5 months after his index scans, and he has now extensive pulmonary metastases, and he's on chemotherapy. You know, I guess the interesting thing here would be what would have, you know, other people done in January 23 when he came in for that offer, and the clinical examination findings were obviously different from his clinic reviews with the surgeons. Would we have proceeded? Would some people have proceeded with a simultaneous nephrectomy and a kidney transplant?
I mean, it looks like you could have put it in on the left. I mean, I think you've done very well to sort of recognize that there was something more sinister going on. I've certainly seen polycystic kidneys really expand after you've removed one. So a year later, the other one's enormous and has grown right across. So that they do change quite rapidly. I know anecdote, but no, I think you've done very well to sort of recognize the problem and put a stop to a further immunosuppression. You're not going to ask us whether we want to transplant them now, I take it, Ashvini. That's not the trick question, is it?
You're definitely off the wait list.
That's a relief.
I just want to, I spend a lot of my time looking at the scans of patients with polycystic disease, and I think I'm not sure you can actually pick renal cell carcinoma very easily, because the cysts really confound the standard diagnostic criteria for renal cell carcinoma. So I think, you know, it's often a bit of a lottery, unfortunately. Even if we do go around getting imaging and evaluating patients really carefully, we're going to miss
Does
some.
that contrast enhanced ultrasounds help at all, or in your practice?
I don't think so. I think they're pretty unreliable. I mean, they're, you know, because the cyst makes the renal parenchyma so abnormal, the ability of radiologists to pick out lesions reliably. Like if you've got such a high degree of suspicion that you're doing a contrast enhanced ultrasound, you should probably just take the kidney out, because even if it's negative, it's not reliable.
Handu?
Yeah, just to make a comment that I think the most reliable imaging is actually serial imaging, whether you decide to do an ultrasound or CT. I think interval changes scattered over a period of time is probably the best predictor, because there's so many hemorrhagic cysts and complex cysts and indeterminate lesions. The other is that these patients, about half the times, they will have clear cell, and the other half is papillary. And of course, when it's a metastatic clear cell, they need immunotherapy, and 30–40% of the patients will reject, which makes obviously transplanting difficult. Papillary, we don't really have good treatments for it. Again, you know, immunotherapy will have some response. Tyrosine kinase inhibitors will have some response, but once it's metastatic and it's non-clear cell, geez, they've got a pretty short life expectancy. I think about 2.5 years is what I recall. So a difficult population to transplant.
Yeah, I think this patient, he was put forward for a nephrectomy after the DCD transplant didn't go ahead. Prior to knowing that the transplant wasn't going to go ahead, we had made the decision not to transplant him, because even though you might be able to, you know, see that he may have some room on the left, he had such a big AP diameter and narrow pelvis, and that kidney was encroaching over the midline, that, you know, getting some room and getting in would have been quite difficult. And so he had a 4-month delay, so he'd get his PD sorted out and get a few life issues sorted out before he went forward for the nephrectomy. So it was an incidental finding of a large tumour, as it turned out, with poor prognostic factors, and he's not done very well at all. But one of the interesting, we have transplanted a few patients who have had incidental findings of much smaller cancers with more favourable prognostic factors. And even though the cysts in polycystic kidneys are supposed to, anybody can correct me if I'm wrong, but my understanding was that they had the same incidence of cancer as to normal kidneys, but they had a much higher incidence of cancer on the contralateral side if they did have a lesion found. And so monitoring them in the post-transplant period would also be interesting. As somebody alluded to previously, patients, you know, polycystic patients with aneurysms, you know, there isn't a clear guideline as to when to or how often to screen them, particularly in the post-transplant period. We tend to get lost in the post-transplant care as opposed to continuing to monitor their other polycystic problems. And it's something for all of us to be, I suppose, aware of and cognizant of. And, you know, it's useful to discuss all these issues to, as I said, to increase our awareness. Okay, does anybody else, we're kind of 8:05, so we've gone a little bit over. Does anybody have any other comments to make before we wrap up?
Just a really good talk and great discussion. So thanks to you both, especially Ashvini, for putting all the slides together. It's great.
Yeah, thank you, Emma, and thank you, Ashwini. And just for information, next webinar is from John Hunter. Animesh and gang is doing that on October the 7th. So please do attend.
Very good. Thank you, Ash. Have a good night, everybody.
Thanks, everyone.
Right.
Bye.